Today, I will talking about the full endoscopic approach for management of the lumbar foraminal pathologies. This is my curriculum vitae. Yes, this photo taken maybe near 8 years ago from İzmir, Turkey, Çeşme, and for the 6th Izmir, Turkey. This beach is very beautiful area. And today is my all photos taken by me in the Turkey. Yes, firstly, we should think about it, why we should starting and development and spreading the endoscopic spinal surgery. We already well known that people's mean life increased abruptly. And also the treatment pattern of the spinal disease abruptly changed from the spinal disconnection to stenosis and instability, and so many degenerative diseases increased abruptly. Fortunately, the spinal disease developed so long time, so several kinds, but we can see that there. Firstly, we starting the open spinal surgery, but there have so many complications. Because of that, we hope to minimizing and some more developing the surgical technique and the microscopic spinal surgery developed. But still, the surgeons hope is not finished completely. The patient hope did not fulfill completely because of that. The more advanced technique needed to development, and fortunately nowadays the endoscopic spinal surgery develops so much, and therefore we can give more good treatment to the patient. But we already well know that the endoscopic spine surgery is spent a long time to develop, more than 20 years and 30 years. We already well known that the first starting the endoscopic spine surgery late 20th century, but true endoscopic spine surgery starting early 21st century. It meaning that only 20 years history. Because of that, still need some developing and researching, and the more good technique to give the more good treatment to the patient. Firstly, we think about it, what is the real rationale of the endoscopic spine surgery. We can estimate that the real rationale of the endoscopic spine surgery from the transforaminal approach, like these cases. You can see here the preoperative and postoperative and final part of, you can see the all structures completely resolved with some completely resolved the pathologic symptomatic point. And you can see here we hope to preserve the all structures from the patient spinal segment with for the good healthy life of the patient. Because of that, we still need some research and development of the endoscopic spine surgery. Because of that, some reader doctors like Gonche and Yong-an and Tony Young and so many doctors talking that the real rationale is the endoscopic spine surgery is less is more. We already well known that the endoscopic spine surgery developed so long time, and we can divide it 4 generations. Firstly, first generation is the starting generation. It is started from the transforaminal approach. It opened from the Tony Young. And the second generation is the intraminal endoscopic discectomy generation. During these 2 generations, we can overcome the all pathology of the lumbar disc pathology by the endoscopically. But nowadays, only first generation and second generation, we endoscopic spine surgery only limited indication from for the disc pathology, and some only focal stenotic pathology like foraminal stenosis. But fortunately nowadays we now going on the 3rd generation and 4th generation of the 3rd generation of the endoscopic decompression and 4th generation of the endoscopic fusion generation. And then now we can expand more widely of the endoscopic spine surgery near all kind of degenerative spinal disease. And also so many doctors like me and some another doctors believe that in the future, endoscopic spine surgery will be the mainstream of the spinal treatment, because there is a real minimized option treatment and more chance to give a return to patient normal life rather than some more aggressive surgery. And among this history, we can divide the generation of the endoscopic spine surgery by two parts. One part is a discectomy generation. One generation is a decompression with or without a fusion generation, meaning that the stenosis with or without instability generation. It is very important because of that. Before time, we only endoscopic spine surgery only treated some limited indication of treatment like lumbar disc herniation and some cervical disc herniation, some thoracic disc herniation. But so many degenerative diseases already change the patient this is pattern from the disc pathology to stenosis with or without instability, because it need a more development technique for the stenosis with or without instability by the endoscopic spine surgery. This is a Taksim area place in Istanbul. Firstly, today's our topic is the foraminal pathology of the lumbar disc. Because of that, firstly we think about that biomechanical consideration, and we already well known that disc pathology also some combination with instability, but usually disc pathology is stable because of that. Disc pathology only managed by the only targeted pathology for the pathology, but stenosis is not only unstable. Usually there is unstable situation because of that. In need sufficient resolving the pathologic point with sufficient preserving the functional segment like facet joint and paraspinal muscle and surrounding ligament structures. Because of that, endoscopic decompression or fusion rationale is very important in this situation. And also the foraminal pathology treatment by the endoscopic spine surgery also very important to according to this aspect. In the foramen, we can see there have so many anatomical structures that compress the nerve, like here disc pathology and foraminal ligament pathology and bony structures, osteophytic bony structures, and around some another structures. Because of that, if we manage the insufficiently foraminal pathology, there is a more higher chance of recurrence or incomplete surgery chance. Because of that, that this is very important. Because of that, during last several years, we can see the several kind of endoscope technique to manage this pathology. But I believe that in the future, we can manage this pathology completely with some kind of technique. Today, I will discuss about that. You can see here the one another important biomechanical consideration is lateral wedging instability. Because of that, usually foraminal pathology, foraminal degenerative foraminal stenosis near or usually combined with lateral wedging instability. Because of that, if we not manage sufficiently, there is more chance to aggravation of that pathology that make the patient pain more seriously. You can see here the very important concept of lateral wedging instability. We can see so many patients so many patients like this wedging instability. If the patient like this stable state, foraminal stenosis can manage it easily. But if like some wedging state, the foraminal pathology not managed easily. Because of that, there this foraminal pathology not only related to the disc pathology or foraminal ligament, but also there you can see the surrounding ligament structures and surrounding bone structures also related to this compression of nerve root, not only dorsal root ganglion, but also nerve root and paracentral compression. Because of that, if we not manage this sufficiently, it can make symptoms or some another symptoms in this area. And you can see here the foraminal stenosis also can classify this several points of pathology like this. Some patients have a overall type of foraminal pathology like this, but some patients main pathology located in the intraspinal canal area, but some patients have some problem the extraforaminal area. Because of that, like this extraforaminal stenosis or pure foraminal stenosis can managed by the transforaminally. But if the main pathology located to the foramen and in spite of the extraforamen that combined with like this fasciitis or some intraspinal canal compression combined, in that situation, the transforaminal approach is not usually not sufficient treatment. This also Istanbul, very beautiful Bosphorus sea. Now we consider the approach, endoscopic approach for the foraminal pathology. I already published this paper in the World Neurosurgery. There we can see the two approach technique of the foraminal pathology. One is a postoperative transforaminal approach. Another approach is a contralateral intraminal approach. Before time, we only doing the transforaminal approach, but after developing the endoscopic decompression technique, contralateral intraminal approach also developed so much in. And also in my cases, I'm doing so many cases of a contralateral intraminal approach because of that. In my clinical experience, there is a more stable to decreasing the biomechanical instability and more good to decompress the foramen and paracentral pathology in spite of the sometimes more extraforaminal pathology can possible using this approach. But transforaminal approach usually not managed many pathology simultaneously. Usually they manage this foraminal pathology area. And these two techniques have some advantage and disadvantage you can see here. Actually, we can see the because of the transforaminal endoscopic discectomy developed a long time ago, and so many experience because of that. It seems like a learning curve is very easy, and like some extraforaminal decompression looks like good, but unfortunately, I already mentioned that they have so many weak points in the transforaminal area. But in spite, rather than the intraminal contralateral approach have only some problem is that the learning curve is so high. But after overcome the learning curve, there have so many advantages in the managing the foraminal pathology, like nowadays we can contralateral intraminal approach can possibly extraforaminal pathology easily, and also intraforaminal decompression, foraminal decompression and facet joint violation is very good, and also some another advantage is that most importantly, DRG approach is an indirect approach. Transforaminal approach is a direct approach. Because of that, postoperative dysesthesia is so low. That study also published in World Neurosurgery by me. Here also beautiful Antalya. I love Antalya and İzmir because the place is so beautiful area. This the photo taken 2014 ACMST. Now we talking about the surgical consideration of the foraminal pathology. What kind of endoscopic approach can apply the foraminal lumbar foraminal pathology? Now we discuss that. Firstly, we can see the transforaminal endoscopic lumbar dissectomy. That is a ipsilateral area, and the contralateral intraminal contralateral endoscopic lumbar dissectomy. And also, these two techniques related to the disc pathology. And transforaminal endoscopic lumbar foraminotomy and the intraminal contralateral endoscopic lumbar foraminotomy related to foraminal pathology. One is ipsilateral, one is a contralateral intraminal. And the final is the endoscopic lumbar interval fusion. These 5 kinds of the surgical endoscopic surgical technique apply to the foraminal pathology. Firstly, we talking about the foraminal HMP. I already mentioned that there have 2 techniques of ipsilateral transforaminal endoscopic lumbar dissectomy. One another is the contralateral intraminal contralateral endoscopic lumbar dissectomy. Firstly, we're talking about the transforaminal endoscopic lumbar dissectomy. Here is Chesame, beautiful place. Transforaminal endoscopic lumbar dissectomy for the foraminal pathology usually can indicate it to the true foraminal HMP without stenosis and above L4-5. Because of that, the L5S1 can possible, but the L5S1 usually is related to some retraction of dorsal ganglion. Because of that, and also higher chance of incomplete surgery. Because of that, L5S1 more advantage from the intraminal contralateral approach rather than the transforaminal approach. Anyway, above L4-5, pure foraminal HMP is a most good indication of transforaminal endoscopic lumbar dissectomy. And additionally, foraminal to far lateral disc herniation without severe foraminal stenosis is an additional indication. We already well known that the transforaminal endoscopic lumbar dissectomy that firstly starting from the Kambin introducing the Kambin's triangle. And I already mentioned that firstly starting from the Tony Young by the inside out technique 2000. But after then, Dr. Thomas Sugland developing that transforaminal approach with the outside-in technique. Because of that, the inside-out technique usually some limited indication, and the outside-in have a more wide indication. But still, there have some limited indication in the transforaminal area. Because of that, 2018, I introduced the mobile outside-in approach. Using this mobile outside-in approach, we can apply all kind of lumbar disc pathology by the transforaminally without L5S1. You can see here the mobile technique of the transforaminal approach, and below video showing some overriding technique of the transforaminal area for the foraminal pathology. This technique is very important to measuring the foraminal disc. I will show again. This is a mobile technique, and this technique is a overriding technique. With overriding the upper vertebral body can easily approach to the foraminal pathologic area. Okay. This patient, you can see here the severe L4-5 disc pathology, 2 cases. And in the transforaminal disc discectomy, most important point is that protecting the dorsal ganglion with a retraction by the working channel. This is very important. You can see the video. First, reducing the Kambin's triangle, after then moving the working channel to the dorsal ganglion area with the traction, but not damage the dorsal ganglion. Should not damage the dorsal ganglion. Then we can see the some ruptured particle to there. Then one more rotation of the working channel with the overriding to the axilla area. Then can more deeply access to the axilla area like this. Then we can remove the disc pathology safely. Then you can see, sorry, postoperatively the disc removed completely. Some another case, in this case is also seems like similar. This 58-year-old male patient, and this L4, this L5. Then overriding the working channel, sorry. So sound is so. Yeah. Firstly, ducking the Kambin's triangle, then finding the vertebral, upper vertebral body and overriding to the foraminal area. Then see the rupture disc. And sometimes can drilling the bony structures. And then anyway, showing this axilla area. And see the some rupture disc material. But we should remind that in the foraminal pathology, disc seems like in the MRI small size, but usually so multiple particle and so huge size. Because of that, should checking more deeply and should checking the final point. The final point is beneath of the dorsal ganglion. And then it seems like they have no rupture disc, but you can see the so huge disc. With the curved forceps, can remove that. And another disc, and another disc, and another disc. Still, a huge disc remained here. I already mentioned that in the foraminal to superior migration disc, final point is that the free beneath of the dorsal ganglion. Here, because of that, should finally checking this free area. Then the page, sorry. Then you can see the disc pathology removed completely. And in these cases, you can see the foraminal to lateral disc that also can apply the transforaminal approach. But in the foraminal to lateral disc, most patients, the ducking the working channel is very serious pain because of that. I recommend rather than the floating technique, rather than the insert the working channel too deeply. Like this, firstly, remove this pathology point, then insert and rotate. Then you can see here, the Kambin triangle here, not ducking too deeply. Firstly, checking the rupture disc here. Then you can see the huge disc beneath the dorsal ganglion. Then we can insert the working channel more deeply. Then finally checking the free area. And then postoperative, you can see the disc pathology removed completely. And this case showing the high level foraminal to superior migration cases. Also, it looks like L1 to level very difficult, but fortunately, L of a high level has some wide foraminal space because of that. In spite of the steep inserting the working channel with a small some drilling of the foramen easily can approach to the target point. You can see here. Professor Hassan, how much time I can get today? Professor Hassan? Professor Hikmet, how much time today can I get?
There is no time limit. You can continue.
Oh, thank you. Then I already mentioned that in the foraminal to superior migration, this usually have no one point because of the should checking the final point of the free area of the axilla area. Then you can see the free beneath the dorsal ganglion area. That is a final. Then you can see the rupture disc removed completely. And this is ipsilateral approach, but some of cases have some advantage from the contralateral interminal approach, especially foraminal to superior migrated foraminal to paralateral L4-5 or L5S1 area without severe foraminal stenosis. For example, in the L5S1 foraminal to superior migration cases, usually transforaminal approach is not easy because of that iliac crest and transverse process and so many bone structures blocking the walking in the foraminal area in L5S1. Because of that, so many Korean doctors and me, we already tried the contralateral intraminal approach. I firstly published this technique 2016 to JMIST. And in the this discectomy usually can perform in the small working channel, but if we need some decompression together, in the cases we can decompression firstly and then change the working channel, the small working channel, then can possible the foraminal decompression and discectomy together. We can see here this cases is L5S1 foraminal to superior migration cases. I already mentioned that this patient also have some high iliac crest. Because of that, if we try the transforaminal approach, usually can fail to extraction of this huge disc pathology. But if we try the contralateral intraminal approach, if it overcome the learning curve, this is also very simple. Splitting the ligamentum flavum or resection of the ligamentum flavum of the contralateral area, then insert the working channel. Then we can see some rupture disc and dorsal ganglion of the contralateral side. And here is the foraminal space. Here is the dorsal ganglion. Then you can see the dorsal ganglion here. Then you can see the rupture disc removed completely. Also, another case of the foraminal to superior migrated cases of L5S, you can see here, backing the working channel to the contralateral ligamentum flavum area and the splitting. Then remove the disc pathology beneath the dorsal ganglion, not retraction of the dorsal ganglion. You can see the dorsal ganglion here. Here is the dorsal ganglion. And also, some of cases like this cases is some paracentral and the foraminal and extraforaminal with some focal stenosis cases. Also, some have an advantage from the contralateral side. You can see here the some operation view. In this case, there was some thickening of the ligamentum flavum because of that. I removed the ligamentum flavum together, then remove the disc pathology from the contralateral side, not retraction of the nerve root. Dorsal root ganglion also not retract. Here is a dorsal root ganglion here. Then you can search all area of the acute nerve root under the endoscope view. And the postoperative view, you can see this view, and 6 months follow-up, the facet joint and all structures preserved completely. Here, postoperative CT image also you can see the facet joint or saved completely. This case also very interesting case. You can see this case have a 73-year-old female patient with a severe foraminal stenosis, extraforaminal disc, and the lateral central stenosis, lateral recess stenosis together. In this situation, contralateral intraminal approach have a so good advantage because of that. This can manage this central stenosis and extraforaminal pathology simultaneously. You can see this operation view. And remove the disc from the contralateral side. Then you can see that here is the extraforaminal area and the nerve root also acute nerve root free. And the postoperatively, you can see the oral pathology managed by the one step. And I hope to discuss for the disc pathology now, and I hope to take less than 5 minutes. Can I take now?
Yeah, of course.
Yeah. Have you any question for this this lecture?
Yeah. You can go on, Professor Kim.
Go.
We have time. Yeah. We have time.
Okay.
Don't worry about it.
Okay. Okay, now we discuss about the foraminal stenosis. Foraminal stenosis, I'm also already mentioned that 3 kind of endoscopic approach technique. One is ipsilateral transforaminal endoscopic lumbar foraminotomy. Second is contralateral intraminal endoscopic lumbar foraminotomy, and the final is endoscopic lumbar intervallic fusion. I already mentioned that this two technique has some advantage and disadvantage, and also if we choose this technique, should think about some lateral wedging instability. This is very important point to decreasing the recurrence. This photo taken from Antalya. Because of that, I think that maybe in the transforaminal ipsilateral lumbar foraminotomy is an indication is that the foraminal to far lateral stenosis with less lateral wedging instability, meaning that if lateral instability is so high and so severe, usually that it has some higher chance of recurrence or reoperation chance. We already well known that some transforaminal endoscopic lumbar foraminotomy done so long time, and it already so many doctors published a good paper, and they talking that the good clinical result. I'm also have so many cases of transforaminal lumbar foraminal cases like these cases, but you can see the lateral wedging instability is not severe. Because of that, postoperative result can show the excellent result, and you can see the some foraminal transforaminal approach and decompression to here, limb, the bony structures and discuss pathology together. And but in the transforaminal endoscopic foraminotomy, most important anatomical structures that the tip of the superior process, because of that pseudo drilling there can make some more widening of the foraminal space with the decompression of the acute nerve root. And also you can see this case is also similar cases with the disc pathology together with the stenosis, but lateral wedging instability not severe. In the cases, you can see firstly docking the working channel to the Kambin triangles, and then some widening of the foraminal bony structures, superior process ring bar. This is a starting point, the point of the superior process. Sorry. After a resection of the some part of the superior process of the foramen, then move to the tip of the superior articular process area. You can see the tip of the superior articular process. I already mentioned that in the transforaminal foraminotomy, most important anatomical structures is here. You can see here the dorsal ganglion. Then you can decompress the tip of the superior process area, then widening the foramen can pass over some decompression of the foramen here. Then also can remove the disc pathology together. Then postoperatively, you can see this image. But I already mentioned that with like this severe wedging instability cases, postoperatively you can see some decompression looks like so good. But I have so many cases, some recurrence cases after long-term follow-up, and they need some cases, some fusion surgery needed, and also. I'm also already mentioned that in the transforaminal approach, also some higher chance of dorsal ganglion and retraction, and hypoesthesia, and some hypoesthetic symptoms. Because of that, choosing the transforaminal needed some cautiously decide. But intraluminal contralateral endoscopic lumbar foraminotomy has several advantages compared to the transforaminal approach. But unfortunately, I already mentioned that there is so steep learning curve and long time learning curve. But anyway, I will introduce this technique because of that. we are always doing the intraminal contracture endoscope lumbar foraminal for the foraminal pathology. And there is an indication is that the lateral recess to foraminal stenosis and foraminal to extraforaminal approach can possible, meaning that the near all foraminal pathology can managed by the intraminal contracture endoscope lumbar foraminotomy. This is technical tips and drilling and drilling and drilling and then approach to the foramen. Then you can see because of that, it can managed by the not only lateral recess but also foramen and the extraforamen can possible. And some patients need a decompression together. We can firstly decompression with the big working channel, then change the working channel, small working channel, like this. Some working channel change can possible channel in channel technique or channel switching technique, but channel in channel technique is not easy to manipulation of working channel. Because of that, I'm now using the channel switching technique. Channel switching technique meaning that firstly using the large working channel, then remove the large working channel and insert the small working channel to there, and then working. And this is a starting point of the contralateral intraminal approach, usually starting from like this blue or round area. And then this is a drilling point here. Then we can approach more deeply to the contralateral foramen. And we should consider that in the foraminal pathology, usually not only some disc compression, but also there need have some ligament, foraminal ligament compression, and sometimes osteophytic compression. Because of that, some drilling, widening of the that foramen with the complete resection of the ligament, foraminal ligament is very important in the foraminal decompression. And this is a procedure. You can see the inner layer of the ligament flavum. Because of that, the resection point of the ligament flavum is here. Should completely finish it to here. Then we can to the approach to the contractor side. And this CM image, docking, and insert the contractor area. This for the only foraminal decompression, not central decompression, because I used some small working channel. Then we can see this image there. This here, this is a contractor axilla area, and then it decompression more. We can see the contractor foramen and extraforaminal area with the dorsal ganglion like this. We can see this cases. This is a contractor lateral recess, and then changing the small working channel. And here is the axilla area. And this is a contractor foramen. Then remove the more additional contractor practical process here. Then you can see the contractor dorsal ganglion with the resection of the contractor foraminal disc here. Here is a contractor extraforaminal area here. Here dorsal ganglion here. Now I already mentioned that you can see in spite of the sufficient decompression, decompression like this, we did not retraction of the dorsal ganglion. Because of that, postoperative dysesthesia can decrease so much. Some another cases of foraminal to extraforaminal and paracentral foraminal extraforaminal cases I already mentioned that the contralateral approach has a more advantage because of that this all pathology by the simultaneously, like this contralateral dorsal ganglion. Then postoperatively, you can see this stenosis decompress completely. And this paper published this year by me for the comparing the ipsilateral transforaminal approach and contralateral intraminal approach for the foraminal pathology. In this paper, I already mentioned that ICLF intraminal contralateral endoscopic foraminotomy have a low postoperative dysesthesia rate compared to the transforaminal approach. This is very important for the foraminal pathology management because of that. The postoperative dysesthesia also so serious complication to the patient. And another very important tip of the contralateral foraminotomy is the final point is this big point. We should find this big point and should resection this area is a final. Because of that, so many patients have some osteopathy here and compression to here, and because of that, the postoperative incomplete decompression made here. Because of that, to checking this point is very important in the contralateral endoscopic lumbar foraminotomy. And also this year, I published the paper for the L5S1 foraminal to paralateral cases. We already knowing that the L5S1 foraminal to paralateral is a far out syndrome. Far out syndrome is also success rate less than 70%, and so difficult to manage the patient. But before time, we managed by the posterior decompression. Some doctors doing the fusion, and anyway, the clinical result is not taken excellently. But if we decompress the ventral this area by the contralateral area, we can take a more good clinical result like this. Because of the contralateral intraminal approach can manage this pathology simultaneously rather than the ipsilateral transforaminal or postlateral approach. Then also can possible to mobile mobilization angle and more deeper working is possible because of that like this management can possible more safely and more easily and can take a more good clinical result. Now we can see the contralateral intraminal foraminal decompression cases. You can see that these facet cyst cases, and this case is also similar. And then you can see firstly docking the working channel and opening. Here is a contralateral area, and then follow the tip of the cranial ligament flavum and splitting there, then searching the foraminal area. This case, first case easily remove the facet cyst. It meaning that the foraminal cyst, foraminal cyst, facet cyst located the tip of the shipriatical process more easily approach from the contralateral intraminal area rather than the ipsilateral area. And after then you can see this postoperative clinical result is very excellent. And another case is we already saw that this case is central stenosis foraminal extraforaminal stenosis cases. Sorry, video not play. Sorry. And one another similar cases with the degenerative scoliosis cases also you can see here. Firstly, doing the central decompression, then approach to the contralateral area and some resection of the contralateral lamina, upper lamina and the inferior articular process, then approach to the contralateral foramen. There have so many osteophytes with the foraminal ligament. Then after removal of this segment, this component, we can check the postoperative decompression can possible. Sorry. Postoperatively, and this patient followed 1 year, 2 years, and the patient still have no pain without fusion surgery. This case is also similar cases, postoperative. This another case is L5S1. Also take an excellent clinical result from the intraabdominal contralateral endoscopic lumbar foraminotomy. Finally, we talking about endoscopic lumbar interval fusion because of that the fusion foraminal pathology final treatment technique will be the fusion surgery. This here is Istanbul. Nowadays, the endoscopic lumbar interval fusion has two techniques of the Kambin approach and postlateral technique. But I use the postlateral technique rather than the Kambin approach because this technique has several advantages. This is a technique for the endoscopic lumbar interval fusion. And here is the docking point. And firstly, in the endoscopic lumbar interval fusion of the postlateral approach, most important point is the resection of the inferior articular process. This is a technique for the resection of inferior articular process. There were two techniques, from inside out or outside in. Anyway, you can see here there's some resection of the superior articular process. Then remove the facet inferior articular process here. After then, resect the superior articular process. Superior articular process also some follow the superior articular border of the pedicle, then remove the superior articular process. And in the endoscopic lumbar interval fusion, the most important technical tip has two techniques. One is adhesive disc drilling. Adhesive disc drilling have so important in the endoscopic lumbar interval fusion because using this technique, we can take a great restoration of disc height and great restoration of focal segment correction. And one another important technical tip is the end plate denudation, not damage the end plate. This is also very important to take excellent fusion rate. Endoscopic fusion rate is more higher compared to the open transforaminal lumbar interval fusion in my study because we can preserve the end plate completely. And this is my instrument of the Harrison cage glider for the cage insertion. It can you can see this bilateral lobe protection. Then finally, then yes, endoscopic lumbar intervallic fusion has several advantages compared to the previous operation. You can see I already mentioned that with the adhesive disc drilling, we can take an excellent correction of the focal segment collapse like this. It also has several great restoration of this height like here. And also great restoration of spondylo in spite of the spondylolisthesis like here. Because of that disadvantage, we can apply this reduction of spondylolisthesis like this. And also we can apply some focal degenerative correction cases like this. And also this focal correction can possible I tried so many cases of this focal segmental degenerative segmental correction and take excellent clinical result. And I already published this result in the World Neurosurgery. And also I already mentioned that in the endoscopic lumbar interval fusion has a so high fusion rate compared to the open lumbar interval fusion. I think that maybe they have three important tips is that in endoplate denudation and the 3D printed cage and maybe DBM block. Anyway, with this technique, we can see these four procedures of the disc fusion process, we can take excellent clinical result. This is my result. I already accept this paper in the Global Spine Journal. They have so rapid high fusion rate compared to the open surgery and so rapid fusion process compared to the open transforaminal fusion and less substance rate. You can see here the one case is of 62-year-old male patient with the focal foraminal stenosis. After operation, you can see the focal correction is very well. And this 1 year's fusion make near completely. And also another case is so many cases I saw the so excellent result only 1 or 6 months follow-up. Some patient to take a fusion and some patient 1 year follow-up. And when you good fusion rate take using the endoscopic lumbar interval fusion. And also I already mentioned that in spite of the so serious collapse cases, we can take excellent clinical result using the endoscopic lumbar interval fusion. I will show the finally some cases of the endoscopic lumbar interval fusion. This patient need a 3-level fusion for the degenerative scoliosis correction with the severe degenerative spinal stenosis. And after operation, you can see the well correction, and the patient take an excellent result. This patient is a very interesting case. You can see here the L3-4 spondylolisthesis with cyst, and after operation 6 months later, the patient take a near complete fusion. And one another advantage finding is that you can see here the postoperatively paraspinal muscle increase in spite of the fusion surgery. You can see immediate preoperative and 6 months later. I searched this finding so many patients, and I'm now preparing the paper. And this case is a 70-year-old patient who already received a kidney transplantation that is not easy to general anesthesia and big surgery. Anyway, using the endoscope fusion surgery, this patient receive excellent clinical result. And after 6 months follow-up, the patient already take a near complete fusion. This photo is very important for me. This photo taken 2013 from İzmir, Turkey. This Tony Young and Thomas Sogland and Martin Knight, Professor Martin Knight. This is my friend, Dr. Roberts. Anyway, in conclusion, the increase in the elderly population and the change in life pattern await the introduction of spinal surgery endoscopically, and the remarkable development of spinal endoscopy over past few years is preparing to enter a new era of spinal surgery. I think that maybe things that seem to last forever change suddenly one day, and we should prepare for the next generation of the spinal therapy. Thank you for your kind attention.
Thank you, Professor Dr. Kim. Now, it was excellent presentation, and you opened new horizon to us from lumbar disc surgery to fusion, and there are some questions. But before these questions, firstly, I want to give privilege to Dr. Hasan Kamil Sucu. Dr. Sucu, do you want to say anything about conference?
No, I'm speechless, and it was an excellent lecture. We learned a lot from Dr. Kim, and you can continue, Dr. Olu.
Okay.
Please.
I will ask something from our colleagues. First question from Dr. Mohammed Nadem. He is asking that, can you tell which dye and technique is used that this looks blue? Is it indigo carmine or another one, Dr. Kim?
Yes, I use the indigo carmine. Unfortunately, indigo carmine product only in Korea. Maybe several months ago, that company they talking that they also finish the production of the indigo carmine. Because of that, so many doctors argue and so many doctors, endoscope surgeon request to product that indigo carmine, and the company come to me and they will start again. And I will share that indigo carmine product to your country, and I will share so many country. I will try.
Yeah. Also, I have the same difficulties, and I am buying from France and Switzerland this indigo carmine. This is very difficult. Yeah. Okay. There is another question again from Dr. Mohammed Nadem. How do you avoid tekal sac while approaching from contralateral side?
Tekal sac?
How do you avoid tekal sac while approaching from contralateral side? Also, there is another question like this. Do you have complication that cauda equina syndrome because of compression of the dura? This question is coming from our young Turkish colleague, Dr. Şentürk, because Dr. Şentürk also operate spinal tumors via interlaminar approach. He is asking this question. Okay.
Thank you so much. Good question. But fortunately, I already mentioned that the starting point is low part of inner part of the contralateral pedicle. And the docking to the contralateral lateral medial border of the inferior process, it makes a so steep angle near more than 45. Because of that, dural compression is not happen there. Okay. I have so many cases of contralateral approach and have no damage to. I have some cases of dural tear, but not the dural compression damage. Have no damage. Don't worry.
Now I want to use my moderator privilege, and I will ask you that. What do you think about the future of the endoscopic surgery for tumors?
That is very difficult question to me because of that. So many doctors ask about that, and I believe that in the future endoscopic trial can possible, but I think that maybe that need so long time because of that. We still like going on the some more difficult cases like some overcome the degenerative deformity and some another cases of some difficult cases not still not try because of that. It needs some long time, but I believe that in the future we endoscopic surgery can possible manage the tumor surgery, and some doctors now doing the some endoscopically assisted tumor surgery, but that is not fully.
Yeah, okay. Thank you very much. Also, there is Dr. Eren from Kütahya, Turkey. He thanks you for your good presentation. And Dr. Murat Shakir, he is writing that one suggestion, please consider analyzing fatty infiltration of paraspinal muscles besides area, since it has been proven more important for muscle functionality.
Actually, the paraspinal muscle is a very important study focus in the future. I'm also focused to that point several years. And also I'm already have so many interesting to the sympathetic connection, especially sinovertebral lobe and vestibular lobe. I already published my two study paper in International Journal of Molecular Science, and pain patient to the vestibular lobe ablation can make increasing the paraspinal muscle volume, meaning that fatty infiltration also calculation of fatty infiltration is very important point to measure the muscle volume in the paraspinal muscle, but still we don't know the how can make some increasing the some not damage the paraspinal muscle in spite of the spinal surgery. But I think that maybe it may be related to the some sympathetic neuropathy, like vestibular neuropathy or sinovertebral neuropathy, and the posterior primary ramus myelinated branch neuropathy can make some paraspinal muscle volume shrinkage, and after blocking that neuropathy can make some build up the paraspinal muscle volume.
Okay, sorry. Also, I missed one question again, Dr. Murat. He is asking that, did the patients have any specific exercise program to increase their paraspinal area following their fusion surgeries?
No. So many doctors, so many people, and also Korean, so many doctors, people believe that postoperative exercise can increase the paraspinal muscle volume. Yes, it agree, but truly, in my opinion, truly, previously should treat the neuropathic point related to the paraspinal muscle volume. That is the first point. If not manage that point, the exercise not give the paraspinal muscle volume increasing.
Okay. There is thanks from Dr. Baran for this presentation, Baran Taşkala from Istanbul. Also, I hope that I am reading correctly. Dr. Podel, he is asking you that, Professor Kim, as you have tools for foraminoplasty, why you have put herniated nucleus pulposus with severe foraminal stenosis in contralateral approach group?
Yes, I already mentioned that in the
is it for preserved facet joint also the continuing? Yeah.
Firstly, preserving the facet joint. Second thing is a complete decompression to there, because of there is a component of dorsal ganglion bounded there. Because if not decompression completely, they make so much postoperative symptoms.
It's okay. Professor Kim, also, if you have time, we kindly ask you that our senior colleague, Professor Aydın. He wants to ask you directly some questions. If you have time, he will ask you. Please.
Dr. Ulu, there is two more questions.
Okay, I didn't see.
Yeah.
Sorry, Professor Aydın. I cannot see here now.
From Yener Erkan.
Yeah, sorry. Okay, sorry. There is another question, Dr. Yener Erkan. While performing a uniportal contralateral approach, do you need to drill the base of the spinous process, or can you reach contralateral side only by opening the flow?
Yeah, that was a very important question. I already showed that point. If there have no serious foraminal stenosis, degenerative foraminal stenosis with some ingrowing of the bony structures and ingrowing of the foraminal ligament, that can possibly easily accept there without damage the bony structure, resection of the bony structures to the target point. But if there have so serious foraminal stenosis and bony ingrowth to the bony structures, then need firstly drilling that component firstly, then can possibly operate there.
Okay. Also, there is a question, Professor Çağlar. How is your experience on the recurrent cases?
Recurrent.
Yeah. He thanks this presentation. Sorry. Yeah.
Thank you so much. That was very important. Yeah. What?
If he wants, he can ask himself. I ask to unmute.
I firstly give some answer. Actually, I already mentioned that the contralateral approach for the foraminal stenosis and disc recurrence rate is so low. But the transforaminal discectomy for the foraminotomy has some higher recurrence rates. And because of the endofusion, endoscopic decompression, central decompression, also recurrence rate is so low. Meaning that usually if I choosing the contralateral approach and this good indication, we can decrease the recurrence in spite of the severe degenerative pathology.
Thank you, Professor. What I am asking, do you have a strategy for the redo cases? I mean, if the first surgery was transforaminal, do you still insist on doing the second surgery transforaminal, or do you prefer switching to contralateral in this case?
I'm doing the transforaminal again. Because of that, I have I think that maybe I experienced more than 20 endoscopic discectomy history. And I have so many cases of the transforaminal discectomy cases. And yes, we believe that the transforaminal approach is some higher recurrence rate. But fortunately, if we first time doing the complete surgery, in spite of the recurrence, after the second surgery can make a near completely removal of the remnant disc. Because of that, in my case, after second surgery, usually the recurrence is very low.